The first session today is Oration 4, Dr. B.N. Ghosh Oration. And for the chair today, we have with us Dr. Y.K. Gupta, Dr. Tapan Kumar Mandal, and Dr. Sameer Malhotra. I think Y.K. Gupta sir is here. So may I request you to kindly take a seat on the dais. Dr. Mandal is here. Good morning, sir. May I request Y.K. Gupta sir and Dr. Tapan Kumar Mandalji to take a seat on the dais, please. The B.N. Ghosh Oration is a prestigious academic distinction established to honor the memory and contribution of Dr. B.N. Ghosh, one of the pioneering figures in Indian pharmacology. Known for his influential work in experimental pharmacology and education, he's played a key role in shaping the discipline in its formative years. The oration recognizes eminent researchers and academicians who have made significant contribution to pharmacology, therapeutics, and drug research. Awarded during major scientific conferences, the B.N. Ghosh Oration provides a platform for distinguished scientists to present impactful research or visionary insight that advance the field. Let me now introduce the chairpersons to all of you. Dr. Y.K. Gupta, sir, we are really fortunate to have you here again, sir, today with us. A renowned pharmacologist and former professor and head at AIIMS, New Delhi. Sir is a distinguished academic leader and he had served AIIMS and later as president of AIIMS Jammu. He had contributed extensively to neuropharmacology, toxicology, drug safety, and played a key role in establishing India's pharmacovigilance framework. So we welcome you here for this session. Dr. Tapan Kumar Mandal is a professor of veterinary pharmacology and toxicology at Bidhan Chandra Krishi Vishwavidyalaya, West Bengal. With a PhD in 1991, over 3 decades of teaching and research experience, he has guided over 34 MVSc and 22 PhD scholars and led 18 research projects, including the ICAR-funded one. He had published over 120 research papers and contributed to a book on xenobiotics. A former dean and vice-chancellor of the university, he currently serves as editor-in-chief of exploratory animal and medical research. So we welcome both the chairpersons over here. I would request you to introduce our speaker, Dr. Chanda Kulkarni.
I think before we start, I would request my co-chair, Dr. Mandal, to say a few words about this oration.
Thank you, sir. Good morning. So, we are going to start the most prestigious oration, Dr. B.N. Ghosh Memorial Oration. Dr. B.N. Ghosh, a pharmacologist par excellence and one of the founder members of Indian Pharmacological Society. His father, Professor Rakhal Das Ghosh, was one of the earliest pharmacology professor in India and wrote a treatise on materia medica and therapeutics. Dr. B.N. Ghosh followed in his father's footsteps and also became an eminent pharmacologist and a pharmacology professor, contributed to the early edition of the Indian Pharmacopoeia, continued to edit his father's book and expanded it to much loved B.N. Ghosh's textbook of pharmacology and therapeutics, which served as the standard Indian authored pharmacology textbook for medical students for over 3 decades. His legacy was carried on by his son, Professor M.N. Ghosh, who established Department of Pharmacology at Jipmar, Pondicherry, and Indira Gandhi Medical College, Simla. Professor M.N. Ghosh instituted the B.N. Ghosh Memorial Oration Award while being the president of IPS. And this is very important that Dr. B.N. Ghosh, so his father was also pharmacologist and his son was pharmacologist, and one of his niece, Dr. Subhadra Mukherjee, she was also pharmacologist. So this prestigious and this eminent pharmacologist, we are going to honor him by memorial oration. So I will request Professor Y.K. Gupta sir to introduce the speaker of today's oration.
Thank you very much, Dr. Mandal. It's my great pleasure and honor to introduce Dr. Chanda. And Dr. Chanda, can you come on the dais? So I know Dr. Chanda Kulkarni for last, I think, nearly 30 years or maybe more, when she was young, though she's still young. But at that time, she was astute worker on epilepsy and continued to work on epilepsy. And we used to read each other's paper because I was working on stroke and epilepsy and she was working on epilepsy. We used to attend together, please come here, several meetings on epilepsy, and later, after leaving active research, she joined a couple of other medical education related organization, and currently she is Director of Medical Affairs at Innovative Drug Development Research Solution Private Limited. She was earlier professor and then she became head of department of pharmacology at St. John's Medical College. And needless to say that she has published more than 100 papers in epilepsy, which is a landmark. And her work was awarded by several international recognitions. And it is very, very rightful to give her this oration. And I was impressed to see the title of the oration, that experiences in epilepsy. But I am a bit worried about the roller coaster journey. I don't think that there is anything which has come like this in your successful journey. It's always gone like this. So over to you.
Namaste everyone, respected chairperson and the dignitaries of the dais. I feel truly humbled and honored to be here to give this oration, Professor B.N. Ghosh. I feel like Miss IPS being here. I'm so excited, yes. My profuse thanks go to 55th IPSCON organizers, because they have really, given us the opportunity to be here and to share my experiences. I'm truly humbled and honored, and the organizers have been taking care of us for, giving wonderful hospitality, and I'm truly grateful to them. Coming to my oration, there are three keywords, as you can see: the research experience, the epilepsy, and the roller coaster journey. So let me try to introduce you. For the young minds around, I think I don't see many. However, empowering their minds is very, very important, particularly being pharmacologists, because we bridge the gap between the prescriber and the consumer. So we play a very major role and a very crucial role, and we have got a wonderful scope to help in patient care or the health care in general. So please remember that we are in the world of diseases. I'm sure you will all agree. However, also remember that we are in a much, much bigger world of pharmaceuticals. So we have to choose our medications appropriately and rationally to help in bringing the healthcare back to normal. Now, the second keyword, as I told, epilepsy. Why did I choose epilepsy? As a child, I'm born, by the way, in a village. I'm rural, from rural India. As a child, I used to always, as you can see me here at the far end of the picture, and this is my mother. Okay, she had bought me a doll, and I used to always complain, saying that why my baby doll doesn't cry, doesn't talk to me, doesn't walk. So she always used to say, "Adike tale illa." That means in Kannada, it has no brain. Your baby doll has no brain. So that inculcated curiosity, and then fortunately I happened to do my medicine in Bangalore Medical College, and subsequently, I did my MD also from Bangalore Medical College, and also did 1 year of residency, senior residency at psychiatry at NIMHANS, that is National Institute of Neurosciences. So right from the beginning, I was very much interested in neurosciences, and I took up my journey in this. So after joining St. John's around 80s and 89 in between, I decided why not pursue PhD in neurosciences. So my topic I took up was epilepsy, and when I read about it, the literature part of it, I came to know that there are three neurotransmitter systems that are involved: GABAergic, which is an inhibitory; excitatory, which is a stimulant; and purinergic systems, which was just newly identified and was said to have a major role in epilepsy. So therefore, incidentally, it so happened that the adenocard, which contains adenosine, was released for cardiac arrhythmia. So I thought the arrhythmia in the heart and arrhythmia in the brain may share similar mechanisms. So I took up further, literature search, and I found that there are several antagonists to adenosine receptor sites, and these are nothing but methylxanthines that we consume in our day-to-day life, as caffeine and theophylline, and also several medications which contain theophylline and aminophylline for bronchial asthma as well as for migraine treatment. So my interest, I took it forward, and also cola drinks also contain some amount of xanthines, and the chocolates, which we really enjoy and relish. So my subsequent, literature showed me that it was Dury and St. Georgi more than a century ago had identified the depressant effects of CNS on the CNS and on the cardiovascular system, and it is because of the release of adenosine that a major seizure that we normally witness as a fit, it comes to, it is self-limiting and comes to a halt because of the huge amount of adenosine that is released during the seizure episode, and therefore they called it as a natural anticonvulsant or a neuromodulator or a neuroprotective agent. Subsequently, it was Astrid Nehle who had published a lot of literature on it, which attracted my attention. I also happened to go to her lab to make a presentation on the various experiments that I had already conducted. So now my journey started with Dr. Joy David entering into our department. Dr. Joy David had already put in some 20 years of service, the research work in monkey models of epilepsy. And she was working at Hindustan Siba Gaigi in Mumbai. Of course, she worked most of her career in, she was attached to Switzerland. And there she did a lot of her work in monkey models of epilepsy, and she entered our department as a research consultant. So that came in very handy for me, and I further took my challenge to do the PhD. Now, as the name itself suggests, Joy David, she was highly joyous, very, very entertaining, and I really enjoyed working with her. Subsequently, of course, a lot of adenosine receptors have been identified, A1, A2, A3, A4, and A1 receptors are said to be implicated primarily in epileptogenesis. Other than that, I also found an interesting article in Neurologic Clinic, and there it said that there are many seizurogenic groups of agents which can precipitate seizures if they are given in large doses. This included the list of methylxanthines as well. So I took it further to identify the role as a hypothesis. I wanted to see the role of adenosine involved in epilepsy. And my first question was, are the methylxanthines that we consume, are they seizurogenic? Do we then need to restrict the intake of methylxanthines in a person who is already suffering from epilepsy? And also, many of the anti-seizure medications that we use in the treatment of epilepsy, do they act through purinergic mechanisms, so that, or adenosinergic mechanism? So with that hypothesis, I went ahead, and of course, as all of us know, epilepsy is nothing but a excessive, repetitive, abnormal, uncontrolled electrical discharge in the brain, and it afflicts about 8 to 10% of per thousand population, and however it is not a mental disorder. Please remember that. It is because of the abnormal electrical activity. So the person who first time coined the term epilepsy was Von Hewling Jackson, and he said in the normal activity the neurotransmitters are well balanced, the inhibitory and the excitatory. However, if you see in the epileptic brain, there is a locus that is generated, which then spreads to the other cortical areas to induce seizures, which becomes a generalized tonic-clonic seizure. A person throws a generalized tonic-clonic seizure, it is because of this spread of activity within the brain. And yet another thing we need to remember is epilepsy has no discrimination between the rich or the poor, the developing, the underdeveloped, or literate, illiterate, male, female. It afflicts all the age groups, including the extremes of age groups. And in fact, recently, more elderly are suffering from epilepsy. And it is a global problem. About 50 million people across the world suffer from epilepsy. And what are the causes for epilepsy? It could be congenital, it could be road traffic accident, it could be vascular, a hematoma occupying, or a hemorrhagic insult within the brain, or the neoplastic growth which occupies the brain areas. Also infestation and infection of the brain and degenerative changes which produce calcified spots in the brain, and medications as I have already mentioned. However, it is idiopathic or cryptogenic epilepsy which is more common among 65% of the patients. Now, what are the lines of treatment? Majorly, the primary line of treatment is anti-seizure medications. No one will go in for any other treatment options without trying out the medications. Then is a vagal nerve stimulation in certain resistant cases, wherein a device is implanted below the collarbone, and surgical treatment for space occupying lesions, and dietary manipulation like ketogenic diet with a high fat and the low carbohydrate diet. That is also tried in certain resistant cases of epilepsy. Now, there are three aspects about epilepsy that each one of us need to know. One is training the healthcare professionals. Education is extremely important to tell them about the basics of epilepsy and what is the pathogenesis of epilepsy, and later on even the post treatment care and the follow up is very, very important. So we have the nursing group, we have the medical professionals who need to be told about it. Other than that, it is also important that we educate the patients themselves. It is very, very important because it's a chronic neurological disease which goes for years together, at times lifelong. So they need to take their medications properly, and that is the reason why we need to educate and counsel the patient right in the beginning, and also the community around them as well as the caretakers of epilepsy. Again, equally important because there is lots of myths and misconceptions that are associated with it, and also a stigma attached to a person suffering from epilepsy. Therefore, educational awareness programs are equally important, and along with, of course, the research, which I am going to briefly talk about. So my next couple of minutes would be the scientific research, wherein I have done some project work, and I would like to share my results for it. Now, coming to pharmacology, the most interesting part is that we have got a wide scope to do research, because we touch upon pharmacodynamics, the pharmacokinetics, pharmacogenomics, pharmacoeconomics, pharmacoepidemiology, and pharmacovigilance, which Dr. Y.K. Gupta, I'm sure that all of you will be knowing that he's into it. So now coming to the outline of my PhD study, I divided my work into three parts: pharmacodynamic studies during ictal and post-ictal phase, and pharmacokinetic study in the normal subjects and among the patients suffering from epilepsy, and lastly, of course, the hospital-based studies, which are more observational studies, like at the level of pharmacy, neurology, OPD, IPD, and the emergency medical ward. So in 1990, my journey began. Okay, now coming to the part one of my pharmacodynamic studies, I studied the interaction between the xanthines, that is theophylline and caffeine, with the seizure protective agents, which were most commonly used those days, that is phenytoin, phenobarbital, carbamazepine, diazepam, and valproate, and challenging doses of the methyl xanthines were given And I studied in two models of epilepsy which are well established, the gold standard, that is maximal electroshock seizure model and Pentylene tetrazole seizure model. And we found very interesting results. And this particular paper was already published in IJPP. And subsequently, I submitted my paper for the IUPHAR, that is International Union of Basic and Clinical Pharmacology, wherein my poster got accepted. Now this is very, I mean, I feel very proud about this poster. That is because, you know, it was a hand-drawn poster. And the bar charts were with the insulation tape. Those days we used to get colored insulation tapes, the blue, green, black, etc. Nowadays, of course, you have, with a click of a button, you know, on the computer you can do it. So therefore, this was presented in 1990 at Netherlands. And interestingly, I happened to meet Professor Adrian Eisenman, who was the head of the medicinal chemistry division, and he was very cordial, and we had a wonderful interaction with him and his students. And therefore, subsequently, he was at Leiden Amsterdam Center for Drug Research in Netherlands. So he invited me to join his lab to do some work over there. And of course, I feel really proud. I don't know whether Dr. Nilima Kshiresagar is around. For the first time, I met her at this particular conference, and our interaction and collaboration started with that. So I'm very proud and very happy having met Dr. Nilima Kshiresagar. So we met at Netherlands during that time. So during 1994, when I visited the Netherlands lab at LACDR, you can see an arrow with one boy standing next to me. He was doing his PhD, Erno von Schaef. So with him, I had to collaborate all my studies, and we were working in the lab right at the top, as you can see the window over there. And it was very interesting because for the first time, I was seeing a snowfall, witnessing. So he took me out to feel the, you know, snowfall. And of course, I was also invited to attend the PKPD symposium on purinergic receptors, and that came in very handy to understand more about the purinergic mechanisms. I learned various techniques at this particular lab, LACDR, and it was very useful for me, wherein I spent about 3 months. And I used to collect all my animals that were already dissected by a very skilled lab technician. She used to do 5 surgeries in a small animal. Please remember, doing surgery on a rat is very difficult. She would put the electrodes on the head of the rat, then she will cannulate the jugular veins on both the sides and also the femoral arteries. That is, vein is for giving that, you know, adenosinergic compounds. The electrodes on the head used to record the EEG and the femoral artery for the cardiovascular parameters. So that is how I started my lab experiments. So from morning at 9 till late in the night, I had to stay back. So then I would also collect some microliters of the blood samples from the you know, jugular vein, and put them in the freezer, and then extract, purify the previous day's sample, and then put them in the automated HPLC. People were asking whether I was baking a cake. Okay, it is not a cake. Those were the samples which were fed in a carousel for identification of the pharmacokinetic parameters. So with this hard work, I could get one international publication, and I was again very lucky to have it. Of course, see, when we start experiments, this is for the youngsters. Don't glue down and go in a single direction. You have to have multiple things going on simultaneously. So I had already started, using the aminophilin-induced seizure model in my lab, which I had myself standardized. And here, the most important thing you should note is I had to give the injections by rat tail vein. Imagine, in the humans itself, we don't find the veins properly. So here I had to give it by the rat tail vein, wherein I had to standardize, then learn the technique, etc., etc. However, it was real fun, and this particular paper also has been published in Indian Journal of Physiology and Pharmacology. Please remember, I'm just going to give you a flavor and a sample of every experiment that I have done, which is different. Otherwise, meanwhile, I have done many more experiments, which I'm going to skip. Now, yet another thing I did was to, design a computer-assisted teaching learning module. This was on pharmacology of anti-seizure medications, because just then we had got our first computer in the lab, and there were 5 of us who had to work on a single computer. So we had to divide our time. Every day, 1 hour morning, HOD will work, the second hour the associate professor will work. So similarly, so I used to get my time, being a junior person, only late in the evening. And then with the help of my student who was really bright and, he helped me a lot. And both of us would sit and design our screenshots and also add animation to each of the drug regarding pharmacokinetics, dynamics, etc. And we had given the entire pharmacology in this particular module, which went in for 1 hour. So it was a user-friendly module, and not that we just did it and stopped at that, but we tested it, we validated it, we published it also, presented in a conference, and this was published in the Indian Journal of Pharmacology. And I was very happy because students had a free time to learn about the drugs that were used in epilepsy, treatment of epilepsy. And they were also very happy, ending with a quiz. So I would sit quietly in the corner, the arrow that is pointing at me, and just observe how the students are using and whether they need any help. And all the corrections and refining of the module was done. And this particular module was also distributed to other colleges. Other than that, of course, I flicked some, adenosine antagonist, a purified compound, and also the adenosine from Dr. Eisenman's lab. Because he was a medicinal chemist, he was manufacturing, synthesizing these compounds, not only on the computer, but he would also synthesize purified compounds. So I could borrow some amount of adenosine as well as the 8-cyclopentyl theophylline, which is more selective adenosine antagonist, whereas methylxanthines are non-selective antagonists. So therefore, my journey again started, wherein I looked at the postictal events and postictal depression, etc. And of course, I gave a dipyridamole, which is a adenosine deaminase inhibitor, which would accumulate adenosine along with the adenosine. And here the new technique that I had to learn was injecting these medications, because adenosine has got a ultra short half-life. So I had to inject the adenosine by intracerebroventricularly. So that was a real marathon wherein I had to prepare and standardize and learn that particular skill. And I could publish yet another paper in IJEB, that is Indian Journal of Experimental Biology. So all this work which I am presenting has been already published. Now this particular paper was accepted for IBRO conference, that is International Brain Research Organization in Kyoto in Japan, and all these people were also working who are standing there. They were also working in purinergic compounds. Now yet another interesting thing was, with my research, Professor Chandradhar Vivedi from University of South Dakota, he invited me to talk about all the experiments that I had done so far, and they also wanted to learn these techniques, so I could spend some time at his lab. Yet another breakthrough was my visit to Lublin, Poland. It was in 1997, wherein I was reading all the papers of Stanislaw Zuzwar. Stanislaw Zuzwar is a Polish man with a yellow arrow, which I have shown there, and he was working on adenosine, and his entire team over there. This is an entire team of pharmacologists in that particular department who are working on various animal models of seizure. And I was very fortunate to meet Zuzwar, who called me again. I spent about 2 months in his lab and learned a new technique, that is pilocarpine-induced seizure model. Subsequently, it was Maria Marta, who is a psychiatrist, who took me to Warsaw, to meet the Polish president, and we had a wonderful interaction there, and I presented all my clinical work that I had done so far. He was a head of neurology there, so it was a wonderful time that I had with scientific feast wherever I went. Now, simultaneously, as I told you, my work was going on. I again tried to have a recurrent generalized seizure model, which would mimic the status epilepticus in the human beings, wherein I wanted to try which of the medications would act there. So status epilepticus, as we all know, is a very serious condition which goes on with non-stop seizures for about 15 to 20 minutes. So I generated that model and wanted to see a cyclopentyl adenosine, which is a very selective A1 receptor agonist. So I wanted to try whether it protects, and to my surprise, it did protect the animals. It was best among the other anti-seizure medications that were used. Incidentally, we also see, whenever you're doing experiments, don't go in a unidirectional fashion. You should see what is happening. You should be very observant. So during my experiments, when I saw, we were doing series of experiments with valproate. What I saw was the animals were throwing, wet dog shakes. I hope all of you know what is a wet dog shake. A dog, when it gets wet, it tries to shake away the water from its body. And that is nothing but a stereotyped movement. So that mimics the obsessive compulsive disorder. Of course, you can't talk about obsession in animals, but a compulsive behavior, a stereotype behavior. So this was a new model which we had created, and that was also published in which is that Annals of Neurosciences. Okay, so my journey started, but then I had done so many experiments, but I found that animal experiments were really challenging because you need to learn the new techniques, you have to standardize them. Then there used to be power shutdown very frequently those days, no UPS. So I had to repeat all my experiments because I will have pre-treated my animals, but then the equipment will not work. So I had to give a washout period, then again retreat them, again subject them for experiment. So I used to lose a lot of my time. And also, there was a ban on animal experiments because QPI came into existence that time, and they did not want us to continue with animal experiments. That was also challenging. So, and the time was ticking, and my professor was after me saying that you have already finished 2 years and you have been going to all conferences, and when are you going to finish? So then, and we had a routine teaching load also, like being an examiner, being a paper setter, being an evaluator, all that had to go simultaneously. And therefore, I decided to start with the clinical experiments in the human beings. Now, I was again lucky to go to Madam Nilima Kshiresagar's lab to have a training in clinical pharmacology, which was funded by CMR. And I'm very lucky, this is Nilima Kshiresagar. Those of you who haven't seen her, she is, I think, going to come tomorrow probably. And then I'm sitting here in the corner. So that was again a very fruitful experience for me. Simultaneously, I did my fellowship in advanced medicine, that is, advanced medical studies, and also a platform course, that is an online course, a virtual online course in epileptology, which was more towards a clinical epilepsy. So I was very happy to do both these courses because that improved my, understanding about epilepsy. Because in the middle of the night, I had to coordinate. I mean, we used to have platform discussions with the people abroad. So I used to spend a lot of time on that. And the good thing is I got 100 on 100 score with this particular virtual course. And of course, my studies in the human volunteers, as you can see here, the challenging doses of aminophylline and caffeine were given for the patients who are already, a single dose of caffeine and theophylline with a single dose of valproate and carbamazepine. To our surprise, the levels of carbamazepine, the pharmacokinetic parameters of carbamazepine were reduced significantly, while that of valproate remained unaffected. So what is the conclusion here? That carbamazepine does implicate purinergic receptors for its anti-seizure activity, while valproate does not involve purinergic mechanisms. So that was our understanding. Subsequently, we did a short study in patients receiving phenytoin also, but we could not do it in larger number of patients, so we could not publish. So this particular paper was again presented at International Epilepsy Conference, Sydney. So one more message to the youngsters: whenever you are doing something, let it have clinical implications. Only then the medical fraternity will be happy to encourage you and they will help you out. Otherwise, it is just a waste. It is staying on the paper, you are reading it in a conference, but it has no utility, no application. So one has to really look into that as well. And I could meet very interesting person during this time, that is Pritika Chari. She is a unique personality in Chennai who has done her both MCH neurology and MCH neurosurgery. So she is a double graduate in neurology. And also Dr. Nadakarni, who is running her own epilepsy clinic. So these are all, encouraging people whom I used to look for. And of course, yet another paper during my so many studies, I found a whole lot of polytherapy with anti-seizure medications, and I looked at the drug-drug interactions between the anti-seizure medications themselves, and then this was presented in Argentina in Buenos Aires. Now, yet another thing I looked at was the hospital scenario, wherein I went into the person suffering from epilepsy in the hospital emergency ward. And this again was published in JCDR, that is clinical and diagnostic research, and we found very interesting results. Now, I'm not going to go into the details. Yet another thing simultaneously we had started was the epilepsy pregnancy registry. This was a very exhaustive study because, see, in order to know the impact of anti-seizure medications on the outcome of pregnancy, you have to follow up these cases more than a year. Only then you will be able to see what is the impact. So I had about 143 cases that were registered, 29 were dropouts, and only 100 and I think 14 cases came for complete follow-up, and we found this list of anomalies, the congenital defects in these 7 babies. So that is something which one has to remember. Just don't go unidirectionally, but you try to expand the scope of your research. So we called it a teratogvigilance other than pharmacovigilance. Okay, so this was published in Neurology Asia. And yet another thing, interesting thing that happened was the use of anti-seizure medications for non-seizure non-seizure effects. So we had newer anti-seizure medications like gabapentin, pregabalin. They were compared with duloxetine. Not that this was an interventional study by me. The patients were already receiving, they used to come for the follow-up to the hospital, and this was an 8-week study. So follow-up studies are extremely difficult. Please remember, you have to chase them, you have to back up, and you have to have many people to collect the data without failure. So this was on diabetic peripheral neuropathy, wherein we compared duloxetine with pregabalin and gabapentin. We found very interesting results, and we had about 4 parameters for the pain assessment. And again, I'm not going to go into the detail. This was published in, again, Indian Journal of Pharmacology in 2012. Yet another thing was about my PhD students. They also have done exhaustive studies, and one of my students, Dr. Ranjana, she had picked up the pharmacoeconomics. Just then the pharmacoeconomics had started gaining importance. So she did cost-effective analysis, wherein again this was a follow-up study, wherein we found topiramate, a new drug along with clobazam, was most cost-effective in the population that we studied. Please remember, the population is not 80 or 100. It was hundreds, 300s, 400s, like that. So please remember, these are all time-consuming observational studies. Although you're not intervening with the drug, you have to do them very carefully, and your protocol has to be very robust and very, strong enough to collect all the information. For this, we had to use a, newly, introduced software for the economic study. It is called as a triage program. So again, we had to, learn that particular program in order to analyze the data that we had collected. Subsequently, of course, these were again observational studies wherein we have looked at the quality of life. Please remember, often quality of life is missed out in your clinical trials. One has to pay real importance to them. Although parameters may show normal, but the patients may not be normal, So therefore, you have to do quality of life studies which should go along with it, and also you have to compare monotherapy versus polytherapy. So that was about that. Also, we have done quality of life in 2 setups, and I'm not going to go into the details. Yet another interesting intervention study was not an intervention. In fact, we used to collect the blood samples from the patients who were already receiving 2 of the newer drugs, that is levetiracetam and topiramate. And this was published in Medical Research, I think, I forget the last part, the name of the journal, but this was published in 2015, okay, wherein we studied the bone-specific biomarkers. Because as all of us know, most of the older generation of anti-seizure medications produce impaired bone health. So they produce, the patients are very fragile, and they may sustain fractures with the slightest injury, and therefore we wanted to know whether the newer drugs would be more effective. However, again, the time limit and the funding constraints. So we had to restrict our study only among 88 patients over 6 months. Okay, you have to do long-term study to see the impact on the bone health. So that was one drawback with this particular thing. Then, of course, again, adherence studies. This is again important because most of the people suffering from epilepsy, they are not often adherent to the medication. They will say, why should I take a medication because I haven't thrown a fit? So therefore, they in between themselves decide not to take the medication. So again, this is a question of your, myths and misconceptions associated with epilepsy, and therefore you have to be very vigilant about it. So we have done many adherence studies also at various levels. Also, we looked at the impact of anti-seizure medications on biochemical and the hematological parameters, which were again significant. So all these papers have been published, have been presented, as you can see here. This was presented in Patna regarding the non-epileptic uses of anti-seizure medications. And of course, we also have, every year that I attend the annual, epilepsy conference, we have what is called as a patient forum. So we call all the people suffering from epilepsy, and we give them a free, freedom to ask any questions to the stalwarts in epilepsy treatment. So here I am, compere for this particular session, which happened in, National Institute of Mental Sciences in Bangalore. So I was very happy to compare, and I used to throw the questions, and the patients would come out with their own problems, and it used to be sorted out. So it is very important that you just don't do research, publish, then you have to also interact, application part of it, which is very, very important. Lastly, of course, I was invited to go to the, as a visiting faculty through EBRO to Sri Lanka, and I could take a training course wherein I shared my experiences. Similarly, in Malaysia, with International Conference in Neurology, Neuroepidemiology, wherein I gave a talk on voice chat between the ion channels, neurotransmitters, and the newer anti-seizure medications. And I also conducted a CME program while I was at Rajarajeshwari Medical College with the help of postgraduate students and the faculty there. And this was a multidisciplinary CME. Please remember, don't stick to only pharmacology. You have to interact with the clinicians as well, wherein we had an endocrinologist, we had a neurologist, we had an Ayurvedic doctor, and we also had a biochemist. So all these things are very important because we are dealing with the biochemical parameters. So whatever you feel is more relevant, you should involve them also to have better application of your findings and of your sharing of the experiences. So it was a wonderful success because we had about, I think, 80 people attending this particular CME. And we used to close the doors there. Let me tell to the youngsters, we will not allow anybody to step out, otherwise no certificate. If you go in between the CME program, you will not get a certificate. So we used to take strictly the attendance and close all the doors of the hall so that they stay put. Okay, so that is something I'm very, very strict about it, basically. Okay, so then coming to yet another experience wherein I happened to go to Israel for a training course. I was very lucky to meet Eugene Trinka, who is standing there, tall fellow. So sorry, not a fellow, he's a president of International League Against Epilepsy. So I was very fortunate to meet him, and then we had a wonderful interaction because I presented my poster on cost of illness analysis. That was part of the economic study that we had already done. Subsequently, I joined Sakrawad Hospital, which is an Indo-Japanese collaborative hospital, and I had a wonderful time there because Japanese team was really very, very encouraging, and they would also participate in most of our activities. And being a member secretary of the ethics committee, I used to train all the youngsters about what is the importance of ethics, how you should go about. Whenever you prepare a protocol, you should be consulting every ethics member, as to how to refine it further so that it doesn't become an unethical study, particularly when we are talking about the clinical studies. So training courses were offered by me single-handedly for, I think, about 8 sessions. And also I was a coordinator for PVPI during my stay at Sakrawad Hospital. And, this particular PVPI, I would like to state that I used a simple instrument like mobile. With a single small instrument, we used to go across 250 beds to collect the information about any medication error along with the adverse effects of the medications. So always the mobile used to be between my staff and myself, and credit goes to all my staff who are really cooperative. They were not medical graduates, let me tell you. They were all clinical pharmacists. So I really, I was really thrilled to see them working so hard to collect all the errors of the medication across the hospital. And we used to resolve the errors immediately with the instrument. So I used to reach out to the heads of the department, telling them that the dose was not okay, the drugs that were given, the combination was not appropriate, and the route of administration was very slow or very rapid, whatever it could be. So with all these corrections and the CAPA measures, we call it corrective action, preventive action. So those CAPA measures, because we are accredited hospital, is very, very important. And we got 2 awards from the Japanese team. The director, the managing director himself gave us the award that was star performance for improving the medication use and also meeting the medical challenges across the hospital. So, and this is a team which worked with me day and night, including during the COVID time. They were posted to the COVID wards, but no hesitation. They would go and collect their information by using the mobile phone and also report and also give the CAPA measures. And these are the Japanese who joined for the walkathon also. So this was for the epilepsy awareness, as I told you, and they also gave a talk, a brief talk to the community around the people who are listening in the hospital. This is Masumi-san, there is a Nagano-san, there is a Takashi Maki-san, all of them, they participated. So that is something which is very, I would say is appreciable. And as I told you, we also launched that particular time by the neurologist, a mobile app for consultation by the patients. So mobile app could be used to, book your appointment and also tell the doctor that you're coming. And then that was Dr. Shivkumar, who is standing just behind Maki-san. So, and our theme was, the logo was lead the change, raise the epilepsy awareness. So they would also join the walkathon in groups along with the nursing team. And please remember the color code for epilepsy is purple. So we always use for national and international awareness programs the purple color. This is just information for those who did not know about it. So coming to the part 3 of my community awareness, all my students during my stay at St. John's for 33 and a half years, they would always participate and cooperate, and they put up a skit or a song or some program which would improve the educational awareness of the patients among in the hospital setup. And also we had a logo for this which was sent by the WHO saying that we should bring epilepsy out of the shadows. So in order to bring epilepsy out of the shadows, it was these students who were just in the 3rd year would join with me to have the educational programs along with the walkathon. And they composed a song called as Cope with Epilepsy. So all that I need to do is just tell them, and they would participate happily, and they would themselves were so innovative, so bright, and so interested. It was a group of only 60 students, but they would spend a lot of time in participating in national and international epilepsy day programs. This particular girl, which I'm pointing out with a white arrow, she's Pratibha Jose. So she is the one who got really impressed. And so further down, during her internship, she was posted to a village, which is a compulsory posting for 3 months. And she did a door-to-door survey in that particular village to collect the information with a small questionnaire, which would identify a person suffering from suspect epilepsy, convulsive disorder. And then we would screen them. So she screened, she went for door-to-door about, I think she covered about 300 odd households in that particular village. And to our surprise, suspect cases were about 33. Out of that, about 3 were truly epileptic with a final diagnosis. So we had to treat them. So that is how you identify. That is how you educate. And subsequently, we had an educational awareness program in that particular village also, with the panchayat who came for our help. So, and this was published in our Acta Epileptologia in 2000. So coming to these educational programs, I just didn't give up. All these educational programs compiled together, I made a poster on epilepsy education at the grassroots level using simple tools. A prototype model was epilepsy, the Indian perspective. And this poster was presented in Australia at the Asian Oceanian Conference in Melbourne. Subsequently, as I'm talking so much about education, why is it important? You may ask me, why is she talking about education? That is because, as you can see from this particular panel, a bus driver who suffered from seizures. When he's a bus driver, please remember, he rammed into several vehicles around because of the seizure. And so many people got killed. This is a recent thing which has happened near Cricket Stadium in Bangalore, just about a couple of weeks back. So this is a fresh news, and therefore education of the patient to be compliant with the medication, to go for regular follow-up, and to see his seizures are well controlled, and not to depend on myths and misconceptions wherein they go for the evil spirit and mantras and all that thing, magic. So therefore, don't depend on that. And some of the people also make the patient who is throwing a fit to smell the old chappal or an onion or give a key in his hand or put an iron rod in the mouth or whatever it is. So these are the myths and misconceptions. Therefore, education, education, education. You need to certainly remember about it. And subsequently, I have also given a talk on which is available on the Facebook. A link is there wherein I gave a talk to persons suffering from epilepsy in Mumbai. This was a Zoom talk which is already available on the Facebook. Also, we had as a Golden Jubilee celebration of our Epilepsy Association, we had organized a webinar which was for women suffering from epilepsy who are already pregnant. So we had a lot of educational material for them, which we shared. Now, I'm really sincere. I wish to extend my sincere gratitude and acknowledgements to Indian Epilepsy Association. I was also on the editorial board, where in every volume for 4 years, I have published the volume with a cover page of all the famous epileptologists. Not a brain picture or a bouquet or our own pictures. It was introducing every single epileptologist who has contributed eminently to the understanding of epilepsy was on the cover page with a short bio sketch. So I had designed, this was my particular idea, and I had brought out all those volumes. And I'm very happy with the good cooperation from the local chapter in Bangalore, Dr. Satish Chandra, Dr. Srinivas, Dr. Subhash, Dr. Sanjeev Sinha. These are all very popular, very eminent neurologists who are a part of our team. And they are also very hardworking, let me tell you. And during our Golden Jubilee celebration, we released our, coffee table book, which was brought out in Jaipur conference in 2022. So that was again a breakthrough, wherein I was again the editor, and I selected the cover page for it with little purplish and the goldish tint. So, my dear friends, you can do, oh, sorry, 2 more minutes quickly. Yeah, anti-seizure medications, their pattern and extent. Okay, I'll skip on this particular thing. These are all observational studies which I have presented to you, and with that I could get my PhD. Now there is much more to explore for the youngsters. Already I have done, work on second generation anti-epileptic agents. Dr. YKG will know there is a third generation which has been introduced, that is lamotrigine, gabapentin, topiramate, felbamate, parampenel. Ask anything and you have these medications, and you can do many studies on these because these are just newly introduced. Not much of the data is available. So to have successful research, you need 3 things: honesty, sincerity, and hard work. And for this again, I will give Japanese as an example, because on one fine day, the toll system failed, and there were 38, it failed for 38 hours, and 24,000 drivers who paid the toll fees online without being asked, without being punished. So they were so, honest and also sincere, because in Japan you will find, those of you who have visited, there are counters called as lost and found, wherein, yeah, lost and found, and you can find anything. So my journey started with a lot of excitement, but ultimately it ended with, happiness, and I was successful. That is because of the teamwork. So, and there were a lot of challenges in, clinical studies as well. I can't avoid thanking my team at St. John's Medical College, my alma mater, particularly Dr. Tangam Joseph, who is standing there with a sari in the last panel, so photograph. So thanks to her. Many of you will also know, and thanks to the IPS 50th IPSCON for giving me this opportunity. And very special and humble thanks to Dr. Prakash Diwan and for Dr. Kalakumar having proposed and having, selected me for this oration. Thank you very much. Can't avoid thanking my family and my son and daughter and my whole team, because they were very cooperative during my absence several times. And of course, my husband, who is standing right there with the, the yellow arrow. And of course, I can't stop giving you this message by my granddaughter. Epilepsy does not define you, but your strength and courage does. Seize the day. I think the voice is not coming. Voice is not coming. Audio is not coming. So she's giving this particular message, and thank you very much for your patient listening. Sorry I have exceeded. Sincere apologies. Sincere apologies. Thank you very much.
Thank you very much, Dr. Chanda. I think everybody will appreciate that condensing your whole life work with such dedication and devotion in just 1 hour is I think, very, very difficult, but you managed it. As this oration is in recognition of your work, we usually don't ask any question or comments except congratulate you.
Thank you.
So,
thank you very much.
Big clap for her.
Thank you.
And thank you very much, Dr. Chanda Kulkarni. Extremely thankful. Over to Dr. Mandal.
Thank you.
Ma'am, please remain here. We need to felicitate you. Thank you so much, ma'am, for such a informative talk, and I would request the chair to felicitate ma'am with a token of gratitude.